Close to 180,000 confirmed cases, 1,460 people dead. Since the first outbreak in Mexico in March, the flu virus H1N1 has spread to all continents. The pandemic is worrying, and it raises many questions about the scale of the virus in the future and the strategies in place to deal with it.
The first thing we need to keep in mind is that there are a large number of uncertainties concerning this pandemic. The responsibility we have as medical professionals is to avoid any excessive response while remaining vigilant. There are many epidemiologists who agree that the percentage of people contaminated could reach up to 30%, with a case fatality ratio of up to 1 in 1,000 due to this new type of flu.
The virus is new and spreading rapidly. The countries most affected, such as the United States and Great Britain, have abandoned the strategy of isolating patients. It's a race against time to produce a vaccine, but it won't be ready in time for the first wave of the epidemic.
We have spoken a lot about the vaccine, although it isn't available at the moment as it is currently in the clinical development stage. It'll most likely be ready for industrial production in September or October, which means it won't be available for the first wave of this epidemic. So to ensure success, the strategy must be to identify and treat severe cases in particular, to reduce the number of deaths as far as possible.
Another concern is the lack of medical personnel, material and medicine in many of the countries where MSF works. They are in short supply like the vaccine. Rich countries have already bought 90% of the vaccines that will be produced this year, against World Health Organization recommendations.
They'll probably be able to carry out priority vaccinations amongst the most vulnerable populations, including children, young adults, pregnant women, and people suffering from chronic illnesses, whereas poor countries will only have 10%. This is a small percentage of the vaccines produced, and at best these countries will only be able to vaccinate their medical professionals. Therefore, we can clearly see that this strategy, initially decided by rich countries, is based on a country's purchasing power instead of a medical strategy.
MSF is ready to help medical teams in countries with the most fragile healthcare systems. The objective is to deal with an influx of H1N1 patients without neglecting those affected by other pathologies. On July 22nd, the Court of Arbitration in The Hague redefined the borders of Abyei province in the north of South Sudan. The decision comes in the wake of violent confrontations in this oil-rich region. In May 2008, the conflict caused unrest throughout the region. 40,000 people fled the city of Abyei, which was almost destroyed. Though the court's ruling favors North Sudan, shortly after it was announced, both parties declared that they would not contest the decision. Southern Sudan is an unstable region. Although peace accords were signed in 2005 after 22 years of civil war, tension remains common, and in 2009 there was an increase in intertribal clashes. In northern Bahr el Ghazal, the situation is calm. Whereas in northern Sudan some MSF teams were expelled, in the south all MSF sections are still working. In Awil, MSF works in the referral hospital of the Sudanese Ministry of Health in gynecology, obstetrics and pediatrics.
In the pediatric department, we have about 175 admissions per month, and the three primary morbidities are respiratory infections, trauma, so that could be things like small accidents and burns, and neonatal sepsis, which is a really big concern in communities where many women are giving birth at home, and there's lots of infections caused in that environment.
Malnutrition is a major cause of death for the youngest patients. More than 2,000 severely malnourished children have been admitted to the program since the start of the year. With the longer hunger gap period, due to the late rainy season, the number of cases could increase. Malnutrition is a factor in certain epidemics like cholera, and in some diseases too, malaria, for example. MSF teams in the field have already recorded an increase in the number of cases. This patient has Chagas disease. Bolivia has the highest prevalence of the disease in the world. Chagas is transmitted by a vector, the triatom, as well as from mother to child and by blood transfusions, organ transplants, or contaminated food. It kills 14,000 people each year. 10 to 15 million are infected. but they may not have symptoms for years. And if they don't know they're sick because of lack of active screening, they receive no treatment.
There are patients who will not have symptoms for many years after being infected, but then there are many others, approximately a third of them, who will develop cardiac complications that could be fatal. Many people are not aware of this. Others, between 10 and 20%, will have serious digestive complications that will also require treatment, medication and specialized surgery that few health systems are able to provide.
For years, political leaders and researchers have ignored this disease. For better patient care, new diagnostic tests, improved medication, and cure tests are needed.
100 years after the discovery of the disease, we really need better access to care so that patients can be tested and treated free of charge in order to improve their quality of life. Mothers who are infected must be able to have their children tested. New diagnostic methods are needed. Tests that are faster and more effective and that can be used in isolated, rural and poor areas. Medications must be improved so as to be less toxic. And finally, we need cure tests for all patients affected throughout the world.
By the end of 2008, MSF had tested over 60,000 patients. Our teams had treated 3,100, and of those, 2,800 patients were cured.